activities, and also he has publications under his name. Research study on role of endocrine cells in arginine vasopressin mediated inhibition of chorionic anion secretion is under his name, and this study was published on Journal of Physiology. Dr. Gayan is involved in many CPD activities and he has good experience in audits. He has done an audit and a re-audit on CSF spectrophotometry for bilirubin xanthochromia sample handling at Gerard Hospital, Oxford. Dr. Gayan's special interests are on lipidology, obesity, parenteral nutrition, and on analytical chemistry. Dr. Gayan's support for our college academic activities is really appreciated and it is a great encouragement to us. Today, Dr. Gayan will talk on assay interference to us. Dear Gayan, thank you for allocating your time for us in spite of your busy schedule. We are grateful for your presence here today, and I'm sure that this will be a valuable experience for all the attendees present in this meeting today. Over to you, Gayan.
Okay, good afternoon to all of you. Thank you very much, Kisari, for those kind words of instruction. It's a pleasure to be here to deliver this talk on this webinar series. So my topic today is assay interference. So I have put some topics I would be sorry, is it moving now? Can you see the slide moving? Hello?
Yes, sir.
Okay, that's fine. Okay, thank you. Okay, just wanted to double check. Okay, so in this talk, I'm going to discuss about definitions which are available about interference. Sorry, types of interferences, mechanisms of interferences. Then the main interferences we know about is plasma or serum indices, namely hemolysis, icterus, and lipemia. Then obviously this is a very vast area and the amount of interferences are quite extensive, but I would try to find some examples, common examples we come across time to time. And then a little bit about interferences which can affect immunoassays, which are very important type of tests we do in our clinical laboratories. Then finally about how to investigate a discrepant result or how to investigate a suspected interference. And if we have time, I have a case which I am already at the moment dealing with about possible interference. So we can discuss that as well if we have time at the end. So to move on, so as you know, the total testing process, which is the process any test undergo, can be divided into pre-analytical, analytical, and post-analytical. So the assay interferences can happen. Some of them are related to pre-analytical stage, but if you take the analytical interferences, that's usually in the that usually happens in the analytical phase. So we would be discussing both pre-analytical interferences as well as analytical interferences in this topic. When we talk about the errors, laboratory errors, nowadays with the development of technology and people using a lot of new assays, new instrument, the manufacturers are continually developing the techniques. Most of these errors seem to be going down but still there are a lot of pre-analytical errors which still needs to be addressed, and analytical interferences are quite low at the moment. Most of the examples you might find in this topic in my talk, some of them already people consider that as almost historical kind of thing, but still it's important to be aware of those things, so that when you come across such thing, it's important to recognize it. And I don't need to tell about the impacts of such if any wrong result or error in result slips through our systems, what impact it has on patients. I don't need to tell this audience, I think. So there are a couple of, so these definitions are from CLSI, Clinical Laboratory Standard Institute. So they have defined interference as a medically significant difference in the result due to a component in the sample or a property of the sample. And similarly, interferent, which is the substance in a specimen that is causing interference with the analysis of another substance. So the definitions are basically self-explanatory in a way. So when it comes to interference, we can broadly categorize them to two groups, endogenous and exogenous. So the endogenous ones are the substances which can naturally be in the blood or produced as a result of a health-related factor or disease or whatever. But they are coming. They are already in the blood. So that's endogenous. So so those are mainly the hemolysis, bilirubin, and lipids, which are the main the serum or plasma indices, and then proteins, antibodies, excessive analyte concentration. Then we all know about Jaffe reaction in creatinine measurement, although nowadays not much used, but we know ketones affecting. So similarly, so these are all endogenous substances. Similarly, exogenous substances are anything which has been added to the blood. So it could be drug, it could be metabolite of the drug, which is again, although it is in the patient's blood, but it's something added from outside. So that's why it's exogenous. And herbal products, IV fluids, then substances used as therapy nowadays. There are a lot of treatment with monoclonal antibodies, then collection tube components, and processes affecting the sample, like in the pre-analytical stage, a lot of things can happen to sample. And then, of course, carryover contamination, which is coming from another sample. So these are all categorized under the exogenous group. So those are the two main groups. So this is just to tell about, I mean, how interference can happen. So there are a lot of mechanisms. I'm not going to discuss them here one by one, but you will appreciate that when we go move on, we some of the mechanisms, the interferences I will be discussing are coming under these topics. So it could be chemical artifacts, detection artifacts. It could be physical artifacts, enzyme inhibition, non-selectivity, cross-reactivity, water displacement, and it could be additive artifacts also. So there are numerous mechanisms, but this is not a complete list, but there may be other ways of other mechanisms as well. This is just a few of common ones actually. So I think in a medical laboratory, the most common interference we come across is due to hemolysis. So I have devoted few slides to discuss about hemolysis. Also, although this is a very common thing, people are very familiar with these things, but I just, for the completeness sake, I have put some slides and a few facts about hemolysis. So most of the time it is, as you know, it is due to sample handling issues. It could be difficult venipuncture, it could be handling or anything like that in the pre-analytical phase of the testing. Even in the labs, now the pre-analytical phase is now in the modern labs, they want to divide it into two phases, like pre-analytical. So pre-analytical is the process which is happening outside the laboratory, but it's still pre-analytical. And then there is a pre-analytical phase which is happening within the laboratory. So within the laboratory also we have to be careful about handling the samples. So not processing samples for a long time, exposure to cooling, heating, fast centrifugation, or maybe imbalance centrifugation, or anything like that can damage the sample and cause hemolysis. So in addition to what can happen outside the wall of the laboratory. One thing we need to be aware of is there could be intravascular hemolysis as well. So all hemolysis is not procedure related or sample collection related, but it could also be that the patient is actually having a pathology which is causing intravascular hemolysis. But again, in the intravascular hemolysis, the chemical profile is slightly different because the body gets the chance to equilibrate most of the things released by the red cells damage in the veins. But in the normal, in the hemolysis, which can happen in the pre-analytical phase, usually all the substances in the red blood cells are accumulating in the blood. So the profile is slightly different, but we need to be aware of that. If a sample continues to be getting hemolyzed, we need to think about that possibility as well. Most of the time it could be the same person or same location or something like that, but this is also something which needs to be careful about. So the interferences can happen due to hemolysis, again, by different mechanisms, as I was mentioning previously. So one common thing is it just can add all the intracellular substances into the plasma or serum. So as you know, potassium, LDH, AST, magnesium, phosphate, they are in high concentration, several times than in the blood or plasma or serum. So when these substances are added to plasma serum, they obviously give high results. So it's usually very clearly seen in the reports. And then hemoglobin can have wavelength interferences in measuring certain assays. So that's depending on the assay platform and the manufacturer. So usually hemoglobin has a wavelength peaks in measurable range, which is used by most of the manufacturers for their measurements. So there is a chance that it can interfere. So I have put this slide just to show what I was telling. So there are some peaks, especially around 415 or so, and then later around 540, 500. So any test methods using those wavelengths obviously can be affected. And if you see that, 340 nanometer wavelength, which is very often used by the modern tests, that is also get to some extent interfered with hemolysis. So it's a real issue, hemolysis, for most of the useful tests. In addition to those spectral and additive effects, it can cause some chemical interferences as well. So few of the well-known examples I have mentioned here. One is the red cell adenylate kinase can positively interfere with CK assays. Again, its manufacturers introduce different things to their reagents, so to negate some of these effects. So you might not find the positive interference in all CK assays with hemolysis. For example, the one we are using in our lab, Roche, they don't bother too much about hemolyzed samples. So at least to some extent. So they obviously have modified the reagents to negate these effects. So that's possible. And then we all know about hemoglobin can interfere with the diazotization of bilirubin. So that is a problem in bilirubin assays. Bilirubin can be degraded by pseudoperoxidase activity of hemoglobin, so giving a low bilirubin result when hemolysis is high. Similarly, lipase activity can be affected, and one other important one is insulin. I think you might have come across, especially this is very important in pediatric patients. In my previous workplace, I remember we couldn't issue many insulin results for children or neonates or infants who were undergoing hypoglycemic screens, because most of the time the sample was somehow hemolyzed. But again, we could use the result in some situations, because we know the mechanism is the hemolysis. With the hemolysis, there are proteases released into the system, and that will cause insulin level to go down. So, for instance, if you find a high insulin result, although the sample is hemolyzed, and as a lab policy, we are not going to report the insulin result, but still that insulin result could be clinically important, because you know that if it is high, the original result should have been even higher, which means which could be a very important important result for the clinical team, because if they are looking for high insulin result, that's exactly what they want. So some of these things we need to be aware of, so then we can even if there is interference, still we can get some useful clinical decisions if we are aware of these issues, and if you are aware of the mechanisms why these things can happen. So moving on, Dilutional effects also can happen, intracellular fluid dilution. So all you know, because there is less sodium, less chloride in blood cells, so these analytes tend to go down in very severely hemolyzed samples. So most of these actions come into play when hemolysis is quite marked, and I think almost all laboratories have to reject when the hemolysis is above a certain extent. Again, as I said, the dependent how each and every assay is affected by hemolysis is different. So if a sample is hemolyzed, some of the results might be still valid, might be useful, so we can report them, but certain results we should not be reporting because they are potentially could be misleading. Similar thing we all in all our labs we look for is bilirubin interference. So we call it icteric interference. So it could be due to conjugated or unconjugated, and there are mechanisms, spectral interference due to bilirubin absorption peak, which is affecting or interfering with the measuring wavelength. If that happens to be around that wavelength, it can affect. Again, chemical interference can happen we discussed that in a bit ago. So again, bilirubin has other properties like peroxidase coupled reactions. Those enzymes or tests which use these enzyme reactions, they can be affected because bilirubin can interfere with these things. So it's very important to check the manufacturer's assay kit, how each and every test is affected, and at what level, because at minor level, yeah, the result may be still affected, but still clinically may not be significant. The other important thing is lipemia, or due to lipids, lipemic samples. So usually this is due to chylomicrons and VLDL. In the blood, usually if you check the triglycerides, they will usually be more than 10 or 15 in most of these samples. But it is not only triglycerides which can cause this, because we are in our assays or in our analysis, what people record for lipemia is actually how turbid the sample is. So it could be due to lipemia or lipids, but it could be due to other things as well. We need to be aware of that. So in this diagram, we can see the dark ones are the ones which can actually cause lipemia. So chylomicrons and some of the bigger VLDL molecules can cause this issue, but LDLs, HDL, so those smaller particles, they don't usually cause lipemia. This is a common problem with neonates after milk feed, infants and neonates after milk feed, and even in an adult after a rich diet, lipid-rich diet, people can get lipemic sample. So whenever possible, especially in outpatient situations, we should try and avoid postprandial blood collection. Again, the mechanism is light scatter due to turbidity, as I just mentioned. So it can affect basically any spectrophotometric reading. And then the other important thing about lipemia is it has a volume displacement effect. As we all know, it can cause pseudo-hyponatremia. So if you are using an indirect ISE method, so we need to be careful about that. Above certain level of lipemia, this can be clinically significant difference. There can be a significant difference. So modern analyzers record it, as I said, as a turbidity. The one important thing to remember is not like bilirubin and hemoglobin, which we can usually reproduce, or if we want to do interference testing studies in our lab, we can make those ones. But lipemia, it's very difficult. You can make, but it doesn't make, I mean, there's no guarantee that it is completely same like in a patient, because it's not only the triglycerides, different other things can give you a lipemia flag. We need to be careful with that. And sometimes you might find a sample is very lipemic, but triglycerides completely normal or just above the normal range. So there is poor correlation between triglycerides and lipemia index. That we need to know. We need to be aware of. One practical issue is when sample is lipemic, yeah, you think it could be hypertriglyceridemia, and when somebody is having a hypertriglyceridemia, you need to think about whether, if the patient is having abdominal pains, you need to think about whether that's pancreatitis, acute pancreatitis case. So one thing you could do is amylase, but we need to be careful about doing amylase in some assays, because amylase assay may be affected by lipemia, and you will get a wrongly low result, and you might exclude pancreatitis. But so that's a issue. So we need to be aware of that. And there are ways of removing lipid interference. Some of them are practical to be done in any lab. Some of them are difficult. Now the gold standard or the ideal way of doing it is ultracentrifugation, but it's usually not possible to do in most of the clinical laboratories. So, but still, sometimes you might be able to get hold of a microfuge or desktop microfuge centrifuge, and they can get up to like 20,000 G speeds, and sometimes they can very successfully clear the lipemia. So there are some studies which have been carried out showing quite good results. So that's something, if you have a microfuge which can go up to those levels, yeah, you can use that. Then LipoClear can be used, or you can just dilute and see if that works sometimes. And obviously for sodium results and those things, you can advise the clinical team to use a blood gas machine to measure sodium. So this is how just to show how the peaks of each thing. So hemoglobin peak, obviously around 415, there's a peak, and then 340 is also affected. Bilirubin has a 450, 460 range affecting, and you can see there is no peak for lipemia, but the any assays measuring using a lower range of the wavelength, lower range wavelengths are more affected than the assays using higher wavelengths if the sample is lipemic. So so that just shows how complicated these three indices. And the thing is, those three indices interfere with their own detection as well. So they interfere with each other as well. So that's a real challenge in another way for the manufacturers actually. The same one with the more the graphic form here. So usually the manufacturers, how they measure these things are not, I mean, in the early old days, I mean, people used to do visual inspection to do these things, but now none of the labs doing that. I mean, it's not practical, it's not reproducible, and it is not objective. I mean, there are a lot of errors can happen. So nowadays, all the analyzers do it automatically. So they do it by diluting the sample. They take a small volume and then dilute it with a diluent, and then they do multiple spectrophotometric scan. And but each and every manufacturer have their own way of doing that, and usually they are not disclosed to others. So all we know is like, yeah, they have checked these things, and then they have in the kit inserts they give us results that for each and every analyte what above which level there is a significant level. So we have to adjust our analyzers, the parameters according to those readings. As I said, one other thing is you can get a high lipemic index when there are high concentration of immunoglobulins, because it is usually the turbidity it is measuring ultimately. Then cross-reactivity is one other thing which is happening, but these days quite uncommon, but still can happen if the Jaffe like chromogens causing interferences, they are very well known, but nowadays obviously people the use of Jaffe reaction is very much getting, I mean, less and less. So again, manufacturers can do different things to modify their assays. They can tweak things to minimize these effects. So after those hemolysis, those serum indices, proteins can also cause interference due to paraproteinemia, and we all know about monoclonal globulins can cause that, and can interfere with spectrophotometry, nephelometry, and turbidimetry measurements. Then they can also interfere with immunoassays. We'll discuss those things later in the immunoassays. Can cause errors in volume sample aspiration. So as we know that just like the lipids, it can cause volume displacement effect, and then sampling aspiration issues can happen, because when the proteins are quite high, the sample can be viscous, and so the results can go wrong in those samples. So we need to be careful about that. One commonly seen effect is when there is paraproteins. Sometimes we see high serum phosphate levels, because because one of the precipitate and reaction between the paraprotein and phosphate that has been seen. And as I said, the volume displacement effect can be an issue with when high protein. So usually when proteins are above 100 or less than 40, sodium can be affected significantly. So maybe good practice to advise using ISC method to measure sodium in samples when you find high proteins or very low proteins. The other way of causing interference is just making macro complexes. So as we know, macro complexes are just they just hang around in the system because they are not excreted in the normal way through the kidneys. So commonly affected, commonly known macro complexes are CK, amylase, LDH, prolactin, TSS. So these can have high results, but obviously they are benign conditions. So it's important for the laboratory to know about the possibility of these things. So one other thing, although this is not truly assay interference, I have just mentioned it. When there is marked hyperglycemia, there is a chance that ECF, extracellular fluid osmolality, is high, and then some of the intracellular fluid can come out, causing some dilution of the sample, and sodium concentration can fall. So we need to be aware of, and then we see that when we treat the hyperglycemia, sodium starts to rise usually. The other important aspect is drugs, important source of assay interference. Nobody can give the full exhaust list of drugs, even the manufacturers cannot provide, but it is very important that whenever we suspect interference or abnormal result, to take a drug history and see whether that drug is actually affecting our assay. So there are good sources if you want to refer to Young's textbook. It's a big database about drug interferences. Ultimately, if the kit insert is not helpful, we can always contact the manufacturer and ask if they have come across anything. If they know, they can help with that. Again, drugs can interfere with different mechanisms. It could be chemical, where the parent drug or metabolite or additives cross-react, which we don't want to measure. Sometimes we only want the parent drug, but metabolite also can be measured. One common example is rasburicase, which is given for uric acid, in Hemolysis syndrome to get rid of uric acid, but rasburicase can work in vitro as well, and uric acid and it will continue to bring the uric acid level down even after collecting the sample. So when you measure the uric acid after some time, you will see very low or undetectable uric acid. So if you want to get a real picture of the uric acid, you need to keep it in ice or maybe do it very quickly, because rasburicase just keeps acting in vitro as well. So we need to be aware of that if you see very low uric acid levels in your hemolysis patients. So I have chosen this one because this has been a very popular thing recently because of certain reason. Biotin is a vitamin B, vitamin B7 is a vitamin B type. So usually circulating concentration of biotin in a normal person, like in a normal diet, it's very low. So it didn't happen to be any problem, but recently, for different reasons, people have been taking biotin in high doses. Especially, there are trials which are trying to use it for multiple sclerosis, and Then about this cosmetic reasons, people are using biotin in high concentration, and that has caused problems for assays using streptavidin biotin mechanism. So that has been a problem because in non-competitive sandwich immunoassays, it can be negative, and then in competitive immunoassays, it can cause a positive result. So that we need to be aware of this possibility if the assay is using streptavidin biotin for its immunoassays for the measurement procedure. So then some of the manufacturers have recently published how much their assays are affected. And with the thresholds also. So obviously we can see some of the assays are affected even at quite a comparatively low levels. Some assays are not affected. So that is also something we need to be careful. Usually usual suggestion is if the patient is taking biotin in high concentrations, they need to leave at least 8 hours after the last dose to use these assays, because otherwise the concentration of biotin in the sample may be quite high for these tests. Then IV fluids can sometimes screw up our results. I mean, we all know about the drip arm. Then patients on parenteral nutrition, if you take a sample from the same IV line, there is all kinds of contamination, and the results just become quite unpredictable, uninterpretable. But the thing is, the slight things may not be very evident, so they can slip through. So it's important that everybody aware of that possibility as well, especially the people collecting blood samples in the wards. Then tube components, as you know, EDTA is a very well-known problem, EDTA contamination. So in those samples, potassiums can be very high, and at the same time, calcium, magnesium, zinc, ALP, they all can go low because of the chelating effect. Then sodium citrate contamination can cause high sodium result. But if you check the osmolality, you will find that osmolality is not keeping with the sodium result, because sodium citrate, the citrate has citrate's osmotical activity is less, basically. So for instance, if you find a sodium of 160, you would expect osmolality to be at least 330 or so, but you will find that it's not the case. You will usually find the normal or 290 to or 300 or lower, even lower. So if there's a discrepancy, you need to be thinking about sodium citrate contamination. Similarly, glucose tubes can cause sodium and high potassium, because sodium chloride and potassium, I think it's potassium EDTA used in these ones, or potassium oxalate, I think. Yeah, sodium chloride and potassium oxalate. So those things can be high. So one way of avoiding these things is to follow the order of draw. So you usually take the fluoride oxalate samples at the end, but take the other samples before. Carryover effect, again, these days very minimum, because manufacturers have introduced very effective washing steps to the analyzers. So that's very, I mean, it's not that common, but again, we need to be careful about sometimes HCG results. If somebody does HCG for a pregnancy test, and then if there was a very high HCG result previously due to a tumor or something, there is a possibility that it could cause a slightly high HCG, causing all the anxiety and everything. So need to be careful about that, and this can happen with the tumor markers as well, because tumor markers also can be quite, the measuring range is quite vast. Antibody interference with immunoassays. We know about the thyroglobulin antibodies measuring, interfering with thyroglobulin assays, and then insulin antibodies can cause issues with insulin assays. So those things when we interpret these results, we have to be aware of that there is a possibility. And in fact, thyroglobulin assays usually, if it is positive, it is not interpretable without the availability of antibody assay. So they are that common actually. One other thing is heterophile antibodies. They are weak antibodies, but they can cause both positive and negative interference. We need to be aware, and they are quite common. They are produced in the body due to different reasons, and they can hang around in the system for different times, different lengths of period. So we need to be aware of that. One other thing is anti-animal antibodies, human anti-animal antibodies, or HAMA. So that also can cause issues because some of these assays are the antibodies are produced in animals. So if we happen to have those ones, they can interfere with the assay and can cause positive or negative interference. And they, as I said, they might be hanging around in the system for different type periods. One other thing is rheumatoid factor. So it's a funny thing. Rheumatoid factor is something sometimes we think it is a possibility of interfering with other assays, but at the same time, when we measure it, the rheumatoid factor can, the same antibody can be interfering with the rheumatoid factor assay as well. And it will, so the heterophile, actually there is a heterophile antibody which is screwing up our one of the assays, and we think it could be, and then we measure rheumatoid factor, and rheumatoid factor is also affected by this same antibody, heterophile antibody. So we need to be careful about that. Sometimes rheumatoid factor is falsely positive due to these heterophile antibodies. So again, if you suspect heterophile antibodies, we can do different things. There is, I mean, people don't advocate measuring them routinely, but you can do different things. You can use PEG precipitation. You can use a different analytical platform. Then there are other things like heterophile blocking tubes, which can mop up these things. And then, yeah, you can check, and then you can do serial dilutions. If non-linear, they may suggest presence of heterophile antibodies. So it is also a significant thing. And some of these things we can do. I think one of the easiest thing would be to check if you have access to send it to another lab and see which is using completely different assay platform or different design, or maybe. Then I have a few things. This is very well known, but it's but still it's important to know about the hook effect. This is mainly an issue with single-step sandwich assays, or single-step assays, basically due to the excess antigen, which can cause the detector antibody to lose, and you can get a lower result. common assays to be affected: prolactin, HCG, growth hormone, tumor markers. So all those things can, because they have vast measuring range. So this is what happens in two-step. Usually when it at the one level it stays same, but in one step you can get a lower result, which is basically the hook effect. There is another thing called variant hook effect, which is due to affecting pregnancy tests due to variant HCG forms. So that we need to be aware of, because sometimes you can get a negative test. It's the same hook effect, but not because of the HCG molecules, but due to the variant HCG molecules, which can happen in mainly molar pregnancies, twins, or even in normal pregnancy. So we need to be aware of that, because they don't act with the normal detector antibody. So they can give a negative result. So it is called variant hook effect, because due to the CG variants. Not many immunoassays are affected by the serum indices, but common things like ferritin can be affected by hemolysis positively, B12 can be negatively affected. So those things, and sometimes troponin assays can be affected. So depending on the assay, so we need to be careful about them as well to some extent, although not like the other general biochemistry ones. So the other thing is about the cross reactivity, but these are now quite uncommon at the moment, because people are using a lot of very specific antibodies. So this is not, not very common, but used to be very big issue in the past. So this is other interferences in immunoassays. So sodium fluoride can be maybe unsuitable for enzymatic immunoassays because of inhibitory activity. Then we know that the gel separation tubes cannot be used for many drugs because it absorbs things and it can give a falsely low result. Fibrin clots can cause immunoassay issues. Then we know about the bind or digoxin toxicity. It can affect the digoxin measurement. As I said, biotin can affect, and I don't have much time to go through this the heparin thing, but heparin can affect free T4 and free T3. The mechanism is not clearly explained, but it can increase free T4 and free T3 levels if a patient has been given heparin. So we need to be careful about that and aware of that, especially in hospital patients. So investigating, we would need to suspect this inconsistent with the diagnosis. If we get a result, if it is not adding with the delta check, in those circumstances, we need to be aware of that there is a possibility, there is an interference. And usually we can repeat and see whether there was any performance issues, sampling issue. But if we are getting the same, then obviously we need to treat it as a proper interference, and we can do all these things like checking with another analytical platform, then different other things like precipitations, dilution studies, extraction methods, very specific tandem mass spectrometry or column chromatography, all those things we can use to investigate the interferences. I think that's all. I think I have a case, but I don't think we will have time. If we have time, we can, but otherwise, yeah, that's all. Thank you. I don't think we have time to discuss the case but I think, yeah, if we have, we can, but it might take another 5 minutes or so. I don't think we have enough time, probably.
Do we have time?
Is it
Hello?
all right? Hello.
Or
Yeah, yes, madam, we can do the case. Yes, Gayan, you discuss the case.
go on.
Okay. Yeah. So this is a case I just came across in my new place actually after starting. So if you have any ideas, I'm very grateful if you have because this is still not resolved. So this is about 31-year-old PE teacher, male patient. He's usually normally fit and well and no medical history, not on any medications, but he had COVID in January and then he had lower lobe pneumonia. I think probably related to that in February. And on monitoring bloods, somebody detected a CK level of 3,311. So we have upper limit around 300. So then this came as a surprise. So we suggested anyway to do a troponin, and then they did the troponin, and it was positive as well. So, but the thing is, at that time, patient was recovering. He was all right. I mean, he was a fit person, and he was systemically well, no problem, and no chest pains, no shortness of breath, no palpitations, no symptoms at all. But so this became a problem. So as soon as the troponin T was elevated, he was asked to be seen by the cardiologist, and they thought, given the lower lobe pneumonia and COVID infection, there could be some subclinical or kind of myocarditis going on. So they gave him that diagnosis, and they just kept monitoring. But CK being monitored, but it is changing. The latest one has been 10,000, but it has at some point dropped to 500 also. So it's very variable. Troponin T has also been done serially. It's always less than 50, but it's always above the upper limit, which is 14. Then somebody suggested, yeah, we'll send it to another lab, another lab, which came as a surprise, as a negative, completely negative. And PEG studies, we did about 50% recovery. So when the sample was 5,000, so still it was showing there was some CK, genuine CK level. So at the moment, we don't know actually what's happening. Actually, the team wanted to do a cardiac MRI to look for myocarditis, but now they are not very interested doing that because troponin I has been negative. So yeah, so at the moment still the patient is completely asymptomatic, but CK is all over the place, and troponin T is still causing positive result. So at the moment, we are thinking about musculoskeletal problem. Maybe although patient is asymptomatic, we thinking about some muscle disease maybe. So we are going to investigate on that line. So again, this is I just choose it because in interferences we usually know that most of the time one assay can be affected, but not two at the same time. But it can happen, but usually it's rare. So, but in this case, the same, isn't it? CK also high, troponin T also high. Both are not clinically in agreement with the patient's symptoms. So, but because both are high, there is less chance that both can be affected. So on that basis, we thought it's myocarditis, but then troponin I coming negative, which is, we don't know actually. If anybody has any ideas, very welcome.
Auntie, can I?
Sorry?
Macro CK.
Yeah, so we have sent, so the PEG study is 50% recovery, means I think, I'm not too sure exactly what we would be expecting, but when the CK was 5,000, we had not actually one of other labs, they did PEG studies and they had a 50% recovery. So that means there could be some macro CK, I thought. But the problem is at one point his CK dropped down to around 500. If it is macro CK, usually you would get quite a, I mean, stable kind of level, isn't it? It's just some change, but it just stays at constant level around mark. Not this type of variation you would see. I thought.
And I'm sure that not renal problem.
No, so no renal issues, and everything is fine. Liver functions fine. I think he's probably a bit of a Gilbert because his bilirubin is high. But ALT, AST, they are slightly elevated, which is probably okay with high CK result. So other than that, he's fine.
Okay. Yeah.
So we don't know actually, but at the moment, we think I have heard in a previous case, sometimes where this chronic muscle disease can cause troponin T, but not troponin I. So I'm just having a doubt whether that could be some kind of very silent muscle, chronic skeletal muscle issue.
Thank you very much,
Gayan. Nice to see you after a long time. I'm Saman here.
Hello, Saman.
Yeah, if it is a skeletal muscle problem, this CK must remain elevated, not like, having a varying level, going down to about 500 and then ranging to about 10,000. How do you explain that?
Yeah, so I thought because at some point probably he might have been asked to not to do any exercise or that kind of thing. So if the muscle condition is causing elevated levels when he doing exercise or activities, it is jumping up, but otherwise it remains just stable at lower level. I don't know. Yeah, I think it's a good suggestion. Yeah, but there is no other way of explaining this at the moment. Yeah.
Yeah, and I like to share your views on a patient. Recently, I came across on a TSH result. So we did this TSH of this patient who came with some joint pain, and the physician wanted to do this TSH, and he was taken a sample somewhere around 9 o'clock in the night, and it was 0.47, and then since the patient was euthyroid, so it's still normal, and they wanted to repeat for some reason. I'm not too sure, and when they repeated on the next day, it was 4.3 or something, quite different, and there was no assay problem. So I was suspecting this interferences of drugs because he was given so many drugs. As you said in your lecture, very detailed lecture. Thank you so much for that. There are so many drugs which some of them have been reported and some of them have not been reported, and so I was suspecting some of the drugs. Are you familiar with this Urimax? That is a trade name. given for the prostatic diseases for relaxation of prostate. I was suspecting that, and some steroids. How your experience on these assay interferences with that kind of drugs? You have any particular drugs which are interfering these immunolysis?
Yeah, so I don't know whether USA is affected by biotin, but because biotin can cause TSH to go low.
No. He was not taking any vitamins. He was not on any vitamins.
Yeah, because
it's again a Roche platform.
Roche is known to cause. Roche is actually one of the platforms which is very, heavily using biotin streptavidin methods. So it can cause, but obviously you might have definitely checked whether, because the next day it came completely normal. That's what I was thinking. I mean, if the biotin level was high at that time, and then after a few hours it comes down to normal levels.
Yeah. So the site is the Young's what is that?
Yeah, so that, yes, so that is good. But I think first thing we would be using would be the patient, obviously the kit insert, and so.
Sorry, I couldn't hear you.
So the kit insert would be the first thing I would be using. Yeah.
But no. Kit insert didn't
say anything.
Yeah. And
so in the first one, so there no pipetting issue or something like that in the, air bubble or something. Can that be a cause? Do you think?
Yeah, that can be a cause, but I couldn't exclude any of those. Anyway, the patient, I'm not having any access to the patient at the moment because that patient was discharged on the following day. But when the patient visits again, I discuss with the physician. So we are planning to do another sample. I just wanted to know your experience on these drugs and TSH and other immunolysis. Yeah, and if you have any particular drug other than biotin.
For the TSH, no, I haven't come across. Free T4 is usually affected by a lot of things because it's a free fraction. I'm not sure about TSH. No, sorry.
And also we have recently evaluated the gel tube, and we checked with few analytes, general biochemistry analytes and immunoassay analytes, and again we have seen interferences with TSH and free T4. So out of 5 or 6 immunoassay analytes and about 5 general chemistry analytes, these two parameters gave problem. I was wondering why, as you said, free T4, maybe because of the balance between free and bound fraction.
Yeah. So what is the platform you are using?
Now these tubes are tested on Abbott Architect and Abbott Architect platform.
Yeah, so I think when I was working in Oxford previously, I think we were also using Abbott Architect there, and I think we had a lot of free T4 flyers actually, and I think at some point we actually decided all free T4 results above 20 to be repeated. So that was a known factor. So some people say like serum, because in Abbott we were using a plasma lithium heparin samples for the thyroids. So we were thinking about changing over to serum samples, which probably might be good. But yeah, some of them were just flyers actually. When you repeat it, it comes completely different result. Nobody knows actually.
Right. Right. You mentioned about hemoglobin index, Gayan. What is the hemoglobin index you use in your laboratory?
Hemoglobin index, it is they give index. Sorry.
Is it 0.5?
No, I mean, for different assays, it's obviously different. So they actually tell you their index, they give you a number, and then they give the relevant hemoglobin concentration if you want to do your own test. So depending on the assay affected, we use different indices. I can't remember the exact numbers we're using, but it's depending on the assays. Like some assays affected quite low levels, and some can just not. They don't get affected at all.
Yeah, I know. No, I understood something like you use a common cutoff for any assay.
No, we don't use common cutoffs. No.
All right. Okay. 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 Thank you, Gayan.
Okay. Thanks.
And Gayan, one question, is it common in your setup, this diurnal variation for TSH? Diurnal variation. Have you come in your setup?
No, madam. We don't we don't ask anybody to check that way. No.
I'm sure collecting blood in the night as well, like for TSH.
Yeah, we do. We have no time restriction at all. I mean, in the hospital, patients, they can have any time actually. They even do. Yeah.
That's the thing. Now the thing is, now for some patients only this happens. Now I have come across a patient. It showed a marked diurnal variation. But it was collected at 12 midnight, and then the following day at 8 a.m. it showed a marked variation in the T-cells. But then for other patients, it doesn't happen. Like the time periods apply for some other patient. It doesn't variation, and it's
so obviously these patients are inpatients.
Yeah.
So the problem is we I mean in general don't encourage anybody to measure thyroid functions in patients. I mean if unless it is very needed. I mean that's what if somebody asked me, I would tell yeah, please check when patient goes home. I mean unless if you suspect profound hypothyroidism or profound hyperthyroidism, don't use the thyroid functions in hospital patients.
They come when they're admitted days.
No, I mean practically we have to do it sometimes, but because of these non-thyroid illnesses,
yeah, that's the problem. Okay. Thank you.
Gayan, there's a question in the chat box. Can you please?
Okay, I will have a look. Usually upper limit of detection immunoassays is very much higher than the upper limit of reference value. How lower result can be due to high dose hook effect? Can it fall within references? I think that is so. The question is, I think, about high dose hook effect. So I think the question is how low a result can be due to high dose hook effect. Can it fall within references? I think that is possible. Unfortunately, we have no way of knowing that. I think it can give completely normal results. So that's the danger about that. So that's why I think, yeah, manufacturers are very, they have done a lot of things now. I think this is not happening that much at the moment. But I mean, if in interferences, it is always important that one of the things I wanted to tell in the lecture is like the clinical team should be in. We should be in with good rapport with them, so that they feel like we are very approachable to them. So if they feel just a slightest doubt about a result, discordant result, they can just email us or take the phone and call us and discuss. So I don't think any other way of picking these things. I mean, if we get to know that the patient is having high levels, then obviously we can start with the dilution straight away. But otherwise, there are no other ways of picking it. I think it can fall within reference ranges as far as I know. I don't know whether I have answered your question.
Right. Fasilas, I believe Dr. Gayan has answered your question. Now it is the time.
Thank you, sir.
Okay.
To stop this forum, let me take this opportunity to invite Dr. Dilanti Varavita, Joint Secretary, College of Chemical Pathology, Sri Lanka, Consultant Chemical Pathologist and Senior Lecturer, Department of Biochemistry, Faculty of Medicine, University of Colombo, to deliver the vote of thanks. Over to you, Dilanti.
Thank you, Dr. Tushar. On behalf of the CCPSL, let me take this opportunity to thank Dr. Gayan Costa, consultant in chemical pathology, University Hospital Sussex NHS Foundation Trust, Royal Sussex Country Hospital, UK. Thank you very much, Dr. Gayan, for delivering this excellent presentation amidst our busy schedule. Please accept our token of appreciation, which will be sent to you in few days' time by post. And next, I would like to thank all the participants who joined with us today and making a very effective discussion forum also. Thank you for your participation and hope to see you in another interesting webinar in 2 weeks' time. Thank you.
Thank you very much all.